can stop sharing, then we'll start again.
Okay.
So good morning, respected faculty and dear delegates. Welcome to the 10th session of e-master classes in pediatric intensive care. I welcome the faculty and the coordinator, Dr. Maninder Singh Dhaliwal and Dr. Dinesh Goyal, Secretary IIP Delhi, Secretary-elect IIP Delhi. I request Dr. Dinesh to say a few words and then over to Dr. Maninder.
Thank you, Dr. Ajay sir. First of all, very good morning to everyone. And it is good to see you in this Sunday morning, every Sunday at 9 a.m. And this is 10th session of the e-master class of pediatric intensive care. And today's topic is cardiac emergencies in children. And it's wonderful, definitely. And thank you, Dr. Maninder, for preparing this whole module. And with this word, I pass on to the Dr. Maninder. Please start.
Hi, good morning, everyone. Thank you, Dinesh sir and Ajay sir, for giving us a platform and IIP Delhi. I would now introduce our speakers and moderator for this particular interesting session on cardiac crisis. As a resident, I was always afraid of the rhythms and always afraid of the cardiac. It's always not easy as a resident to distinguish between respiratory and cardiac causes. So we have, first of all, I introduce my colleague, Dr. Dhirendra Pratap. He is working with me at Amrita Hospital, Faridabad, taking care of a 14-bedded PICU. And he has done his fellowship with us only at Vedanta Medicity. The second is my close friend, Dr. Sajid Keswan. He will be the moderator. He is from our sister institute, Amrita Kochi, and he is trained at KKTCH. Then he went to Sick Kids. He has multiple fellowships, lot of research papers, and really into ECMO and cardiac patients. So it's wonderful to have you, Sajid, here with us here. And I'm sure there are going to be many questions, and I want you, as you answer, always very conceptually. And then we have our speaker for us, Dr. Shubhadeep Das, again a very close friend. And I would say I have not seen a person bring out 15 papers from a pediatric cardiac ICU in 1 year. So congrats to Shubhadeep. He has done wonderful, wonderful work at NH, West Bengal, Havda. And again, he's trained abroad and with multiple fellowships, both in UK and Canada. And I welcome Shubhadeep to please start the session on cardiac crisis and make it very simple for the students.
And before that, we welcome Dr. Pankaj Garg, President IIP Delhi, and request him to say a few words.
So, good morning and welcome all delegates. Sorry for being late for 2 minutes, but yes, it's going to be a great session. I look forward to a lot of discussion in this session. Please start.
Thank you. Over to Dr. Shubhadeep. Please share your screen.
Sure. Thank you. First of all, Doctor, am I audible?
Yes, you are audible.
Yeah, you're well audible. Great.
So, first of all, I would like to thank Dr. Maninder for this very kind introduction, and Delhi IIP, everybody in Delhi IIP for giving me this opportunity to speak on this platform. So what I'm going to do is speak on some cardiac emergencies. As Dr. Maninder mentioned, I'll try my best to keep this as simple as possible and palatable and digestible for the residents. So we'll look into two case scenarios, basically. One on cardiogenic shock scenario and one based on a rhythm scenario, an arrhythmia scenario in post-op cardiac ICU. Right. So with that, I'll just straight away go into this case scenario, the first case scenario. And what I would like to do, just to make this a little bit more interactive and just to give you some food for thought, I'll just probably pause in between for a couple of seconds, just let you try and think on the answers, right? So with this, I'll go ahead. Our first child is a 2-year-old girl, previously healthy, and she had a 4 days history of runny nose, cough, and fever with decreased food intake. And since one night, she started to have difficulty in breathing. The parents took her to a clinic with respiratory distress, some wheeze, as she was found to be quite tachypneic there, and was nebulized a couple of times and referred to an hospital emergency. So now you are in the hospital emergency and you find that the child is quite irritable and crying, although she is a febrile, she is having some retractions, she is tachypneic, she has got bilateral Krebs and wheeze, saturation was initially in the 80s, and now with 10 liters of oxygen went up to 96%. He was a bit tachycardic. The pedal pulses were palpable but feeble. The peripheries were cold. Capillary fill time was around 4 seconds. Non-invasive blood pressure at that point of time was acceptable. And you find the liver was around 3 centimeter below the right costal margin. So I'll just pause for a couple of seconds here, give some food for thought for you. And so what is the physiological status of this child at this point of time? Some respiratory distress, pedal pulses are a little bit feeble, some wheeze and creps. And what are the differentials that I would think of at this stage? You could think, and if you want to answer, probably, I'm not sure whether it's possible, but you could probably write down in the chat box. What do you think about this? All right. So moving forward, for me, this child is in respiratory distress, right? This child has got tachypnea. This child has got subcostal retractions. This child has desaturating a little bit. So definitely respiratory distress. And probably there is some compensated shock because the child has got tachycardia, capillary fill time is on the higher side, and the pedal pulses are poorly palpable. Although the blood pressure is all right. So this child is in shock, and at this point of time, I would classify this shock as compensated shock. Going back to the pulse teaching, so this is compensated shock. And what could be the reasons at this point of time? The differential diagnosis which would run through my mind would be, one is it could be a bronchiolitis, it could be a wheeze-associated lower respiratory tract infection with some septic shock, given that the child had some fever, or it could be a viral myocarditis with cardiogenic shock. So these are the two broad differentials which would run across my mind. All right. So next couple of questions for you. So now that we think of some differential, what would be the next management steps? And what are the special precautions that you would take in view of suspected cardiogenic shock? Okay. So the child is in some respiratory distress. So it's totally reasonable to start some high flow nasal cannula, oxygen at this point of time. The child has got some wheeze, so it's not absolutely wrong if you say, if you nebulize the child with salbutamol and assess the response, how the child responds to salbutamol nebulization, and the child has some is in some shock. That's what we said. So put an IV line. And then give the first dose of antibiotics, because you remember one of the differential diagnoses that we thought of was septic shock. Okay, and because also this cardiogenic component is in our mind, so we can give fluid bolus, but we have to be a little bit cautious with the fluid bolus. Okay, so fluid bolus, even if tried, has to be a little bit on the less generous side, like 5 ml per kilo. It could be tried over half an hour to 1 hour with close monitoring. You stand beside the child and keep monitoring. You palpate the pedal pulses, whether pedal pulses are becoming any better. Whether the liver size is increasing, which would again classify that the child may run into decompensated shock. Now, always in emergency, we have this facility of doing focus. So do focus early, keep on checking on the IVC diameter, keep on checking on the functions. And always in these situations, when we are thinking about a cardiac component, it's absolutely essential that we always, even if the child has a peripheral cannula, we are always open to this idea. Like, the child might require some inotrope, some adrenaline running through some adrenaline or whatever inotrope you are used to it, like running through the peripheral line. Like I've often seen among these residents, like, we don't have a central line. How can we run adrenaline? But under these circumstances where we are thinking about a cardiogenic shock, that the child might decompensate with fluid bolus, we have to keep this in mind, that even if the child has got a PIV, we can give inotropes through a PIV up to a certain concentration. Okay. And then if the child is having more respiratory distress, we have to be ready to institute non-invasive ventilatory support or other forms of higher ventilation. Okay. So let's see. What did we do in emergency? So the child received back-to-back nebulizations with salbutamol and was shifted to PICU. The child was started on high-flow nasal cannula oxygen. Some baseline blood investigations were sent. Fluid bolus 5 ml per kilo was started slowly, and the first dose of antibiotic was given. At this point of time, chest X-ray, ECGs were already done. So I would like you again to think about this X-ray. What does this X-ray show? So again, for me,
So Shubhadeep,
yeah,
there is a Q&A session box on the top. There, audience can type there and you can see the answer there. Can you see that?
not yet, because my screen is full screen right now.
Okay. Then it's okay. Continue.
Yeah. You can check that later. How many of them got the answers correct? So for me, there is a bit of cardiomegaly. I hope most of you can appreciate that. There's a bit of pulmonary plethora. Yes, no, but for me, yes, probably a bit of pulmonary plethora. And then this ECG. So this ECG for me, has got sinus tachycardia. There is some non-specific ST segment changes. So just to remind, what are the ECG changes which can happen in myocarditis? So most common is sinus tachycardia. There can be non-specific ST segment and T wave changes. And you can see there is a whole list of changes which can happen in ECG in a case of myocarditis. But the most important point to remember here as residents is that acute myocarditis can happen without any ECG changes. Okay. So if you have a clinical suspicion in mind, always think that acute myocarditis can happen with ECG, without ECG changes. Now, you did focus, I said, and this is your finding on focus on the heart function. So can you comment? You can, as Dr. Madinda said, you can write down your answer in the Q&A box. So again, this shows significant left ventricular dysfunction. Probably there is some right ventricular dysfunction also, systolic dysfunction. And you can see there is some amount of MR. I would classify visually as moderate type of MR. Okay. Definitely there is some cardiac involvement, which we have found now. And we have done the lung ultrasound. You can see a lot of B lines there. Okay. So which shows congested lung. And I cannot run this video, but this is, I would say, this is a non or less collapsible IVC with minimal respiratory variations, which is quite distended. So we have these focus findings, and remember, like we had already started the child on some fluid bolus to run slowly, and now 20 minutes of fluid bolus is over. The child became more drowsy, respiratory rate increased, the child's even on high flow oxygen, the child's saturation dipped, the heart rate went up to 170, radial pulses became more feeble, capillary fill time became more prolonged, and now the non-invasive blood pressure, which was initially reasonable, now has started to fall. So what could be the potential reasons for this clinical deterioration? And is fluid contraindicated in all children with suspected cardiogenic shock? Now, if we go back to our physiology days, I'm sure that you all remember about this curve. This is the Frank-Starling curve. So what does this say? The more you stretch muscle, the stronger contraction you get from the muscle. But this is up to a certain point. Okay. Beyond a certain point, the more you stretch the muscle, you are not going to gain enough power. Okay. And then the line is going to flatten out. So heart muscle, up to a certain point, if you stretch by giving more fluid bolus, as in like more preload, you are going to gain more contractility out of it. Okay. But then after a certain point of time, even if you add more preload, you are not going to gain any further advantage. And in these children with poor myocardium, with poor systolic function, with cardiogenic shock, they operate in a flatter portion of the Frank-Starling curve. So in what did we ask? Our question was, is fluid contraindicated in all children with cardiogenic shock? Where there is a fraction of children who may still benefit from a little bit of fluid bolus, like this portion here, where my arrow is pointing, and you might still gain some advantage. But we have to be very, very careful that a little bit of more fluid, a little bit of more preload can totally tilt the balance. So as I said, that under these circumstances, if you suspect a child with cardiogenic shock, you can try a fluid bolus, but try a small aliquot and very, very slowly. Okay. So if you have to try, you try it over my practices over 30 minutes to over 1 hour, and I would just stand beside the child. I would keep monitoring the pulses. I would keep monitoring the sensorium. I would palpate the liver, whether the liver is becoming more enlarged. Okay. Now, sometimes it could be confusing because this child whom we are suspecting could be having a bronchiolitis also. Because of air trapping, the liver can be put down. But again, you don't interpret your conclusion with only one sign. You have to put everything into clinical context, and then you kind of interpret the signs. Okay. And if there is definite evidence of congestion, like on your focus, also on clinical examination, you find that the child has got bilateral Krebs, the child is quite tachypneic, then it's better to avoid fluid boluses. In case of worsening shock, what did we say? Always be ready to start some peripheral inotrope infusion. And if there is respiratory deterioration, then be ready to institute positive pressure ventilation. Now, we always say about positive pressure ventilation helping in cases of cardiogenic shock. And do we know how? So one is positive pressure ventilation will eliminate your warp breathing. The child is quite tachypneic. So the warp breathing is eliminated, and it reduces the load on the myocardium. Second is you apply PEEP, right? So whatever pulmonary edema there is, it will displace the pulmonary edema and it will improve the oxygenation. Number 3, positive pressure ventilation will reduce the preload because it increases the afterload to the RV, as a result of which increase of afterload to the RV, the preload on the left side of the heart will be less, and hence your end diastolic volume, your pressure volume interactions, they might become better. Hence your afterload to the LV is optimized. And in a way, when you put the child on positive pressure ventilation, many of the times you would sedate the patient. If the child is ventilated invasively, you would paralyze the patient also. So in that way, it reduces the metabolic demand. But one of the most significant ways how positive pressure ventilation would help the left side of the heart, or would help the heart overall under these circumstances, is by reducing the afterload to the left ventricle. And how does it do that? It's quite intriguing. So it's the concept of transmural pressure. So as you can see the picture here, I'm just going to take some time to explain this picture. This is how positive pressure ventilation reduces the transmural pressure. So what is transmural pressure? The transmural pressure is the pressure across any hollow pipe. So it's the pressure inside the tube minus the pressure outside the tube. What is the transmural pressure for the left ventricle? For the left ventricle, it's the pressure that it has to see downstream, so the transmural pressure across the ascending aorta. So it's the pressure inside the ascending aorta minus the pressure outside the ascending aorta. Okay, so that is the transmural pressure for the left ventricle. Now this transmural pressure is the pressure against which the left ventricle has to produce stretch in order to contract well. So that is the afterload. Okay, so what happens in spontaneous ventilation? Let's imagine this scenario. What is the pressure inside the ascending aorta at the height of inspiration? It will be your systolic pressure, right? So let's say let's give a systolic pressure random number. Let's say the systolic pressure is 100. Okay. Now, what is the pressure at the height of inspiration? I don't know, but it's some sort of negative pressure. Let's say it's minus 10. So what will be the transmural pressure across the ascending aorta? So it will be 100 minus 10. So that will be plus 110. Okay. So this is the transmural pressure against which the left ventricle has to stretch. Now, if the child is put on positive pressure ventilation, what happens in positive pressure ventilation? The name is positive pressure, right? So what is the pressure at the height of inspiration? It's positive. Let's give it a number. Let's say you have set the peak inspiratory pressure at 20. So now, what is the transmural pressure at the height of inspiration? The systolic pressure remaining same, which I said was 100. Now it will be 100 minus plus 20. So now it will be 80. So 80 is the transmural pressure against which the LV has to stretch right now, against the transmural pressure of 110, which we said was the pressure during spontaneous breathing. Okay. So this is how one of the most important ways by which positive pressure ventilation will reduce the work of the left side of the heart and be helpful in this scenario. Okay, I can come back to this concept later on if you have any doubts. Okay, moving forward. So this child was put on positive pressure ventilation, was put on non-invasive ventilation initially, but the child could not cope. The child still kept on having significant respiratory distress. So we decided the child needed intubation. What are the concerns for intubation in this child? Okay, so one of the most important concerns would be the airway might be an easy airway, but this is a physiologically difficult intubation. Okay, so this is a physiologically difficult airway, may not be necessarily an anatomically difficult airway, because remember, this child is very, very hemodynamically unstable. There is depressed ventricular function. So any sort of sedation, any sort of paralysis you use during intubation, these children have got high risk of decompensating and totally arresting. Okay, but also having said that, we should not delay intubation, because then these children can go into decompensated cardiogenic shock. And during inspiration, remember that positive pressure ventilation, while it's helpful to reduce the afterload to the left side of the heart, it also reduces the preload. So while it may be helpful, but at the same time, while applying positive pressure ventilation, the cardiac output may drop because the preload may reduce. So you have to be prepared with volume. You have to be prepared with inotropes, and in good centers where there is facility, you have to be ready to go on to ECMO in case these children have cardiac arrest. But the most important point for me is that the most experienced intubator who is around, the most experienced person should only attempt intubation under these circumstances. All right. So what are the precautions that we need to take during intubation? One is we choose induction agents very, very carefully. Now, these are some of the induction agents which I have listed. You are very well allowed to write in the answer box which one would you choose: ketamine, fentanyl, propofol, or benzodiazepine. Now, no induction agent is so-called cardio safe. Okay, all induction agents can cause myocardial depression, can cause reduction of blood pressure under these circumstances, and can be very, very dangerous. Okay, but still, if I have to choose something, then I would probably not choose propofol. I would probably not choose benzodiazepines under these circumstances. Fentanyl, ketamine in appropriate doses with close monitoring can still be okay, but I would definitely not choose propofol. A very good agent can be etomidate, but etomidate is not available everywhere. Okay, and a few things I already discussed before: how to prepare for intubation. So before intubation, one of the very good practices would be to start adrenaline early, because we anticipate the child may decompensate. Okay, swift intubation, as I said. Optimize pre-oxygenation by bagging or by using non-invasive ventilation, and be ready to go on to ECMO if the facilities are available. All right. So going forward, the child was intubated uneventfully and was put on mechanical ventilation. You can see the child was on 60% FiO2. There are still bilateral crepes. The liver is like 5 centimeter below the right costal margin. There is some metabolic acidosis on the blood gas. Lactate is 3.4. The heart rate is 180. Sinus rhythm, radial pulses are palpable, feeble. At this point of time, CVL was put in, arterial line was inserted. The child was on the hypotensive side. The CVP was 10. He was on adrenaline of 0.05, milrinone of 0.25. Urine output was 0.6 ml per kilo per hour. And now the cardiologist did formal echo. It showed similar findings. What we had seen in the POCUS, ejection fraction was around 25%. And we also did a repeat lung ultrasound, which showed diffuse B lines and distended IVC. Okay, so what are the ways by which, so this is a cardiogenic shock, right? So this could be a viral myocarditis, but this is definitely a cardiogenic shock. And now the child is already intubated with some amount of iron. So what are the ways you can classify cardiogenic shock based on the pathophysiology? And do you think that these classifications could aid in the treatment? Okay. So cardiogenic shock, I would like to draw your attention to this figure. I don't know whether you have come across this before, but cardiogenic shock actually runs through 4 phases. Okay, you can see A, B, C, and D. It's not perfectly clockwise, it's not perfectly anti-clockwise, but it's like the patient could be warm wet. So warm wet, what does that mean? The patient has got signs of congestion, the liver size is increased, the patient has got bilateral crepes, the JVP may be increased, but you have got signs of good peripheral perfusion, like the peripheries are still warm, the pedal pulses are okay, the cap refill time is okay, the urine output may or may not be okay. And patient could be warm and dry. Okay, so warm and dry, what does that mean? The patient does not have any signs of congestion, the patient is well perfused. So this is the state where we want the patient to be in after different forms of therapy. The patient could be cold and wet, which means the patient had signs of congestion along with the signs of poor perfusion. Okay, so decompensated cardiogenic shock. And one of the very bad things is cold and dry. So the patient has got no signs of congestion, but the patient is very cold. So this is a very bad sign. But at this point of time, what do we see? Our patient, which stage is the patient in? The patient has got signs of poor perfusion, peripheries are cold, cap refill time is more, the pulses are feeble, and the patient has got bilateral crepes. The patient was tachypneic, so the patient falls in cold and wet stage. And our management point. So these classifications can be important in guiding your management principles. So at this point of time, because the patient is wet, the patient is congested. So what does the patient need? The patient will benefit from mobilization of some fluid out. So the patient might benefit from diuretics. And the patient is cold, poorly perfused. So the patient might benefit from escalation of inotrope. But remember, like diuretics may not always work well. If you have got good perfusion, your perfusion to the splanchnic circulation, to the kidneys will also be poor. So despite giving inotropes, these patients, and despite giving diuretics, the diuretics might not work very well unless you optimize your perfusion a bit. Okay. So our management principle at this point of time, now that we have classified that our patient is old and weight, would be to optimize the inotropes and also start some diuretics, okay, once the BP stabilizes to a reasonable level. So the current inotrope regime I told already. So going forward, the patient is on some adrenaline, on some inotrope. So what would be the ideal inotrope at this point of time? So I have listed few names. Could it be epinephrine? Could it be milrinone? It would be dopamine. And how do you select on this? Okay, again, people have got different choices depending on their understanding and depending on their unit policies. But what is your choice at this point of time? So let's look into all this. So milrinone is a great inodilator. Okay, it has got minimal impact on myocardial oxygen consumption and heart rate, but this patient is slightly on the hypotensive side. So while we want to start milrinone, but because it reduces SVR, we have to be mindful that this can cause further hypotension and poor perfusion pressure. Dobutamine, again, dobutamine is something which I don't use very often, don't use to be very honest, but it's something which many ICUs use, and it's a useful option. It's at this borderline blood pressure, and it also to some extent it's an inodilator, but there are risks of tachycardia. So you have to be very mindful about the risks of tachycardia, because if the patient becomes more tachycardic, essentially you are doing what? You are essentially weeping an already tired horse. Okay, and adrenaline at this low blood pressure, it's safe to continue adrenaline for now. It's a good inotrope. Again, after some point of time, if you keep on escalating the doses of adrenaline, the chances of other side effects set in, like the patient becoming more tachycardic and stuff. And adrenaline can be used with other inotropes or inodilators like milrinone, okay, depending on the blood pressure. So in our unit, if this was the scenario, typically because we do have a supply, there is now some evidence that an inodilator called levosimendan would be advantageous. We sometimes also would use milrinone, okay? That would kind of reduce the afterload to the left side of the heart and be beneficial. At the same time, it's an inotrope. But at the same time, remember, as I said, that we need perfusion pressure. We need perfusion pressure to the end organs. We need perfusion pressure to the brain. So we want to maintain a pressure head. So some noradrenaline along with milrinone, along with levosimendan would be typically our choice. But it's a much difficult thing to do and easier said than done. So you have to stand at the bedside, and depending on your understanding of the current physiological status of the patient, you have to decide on your inotrope choice. Okay. And now let's see what happens with the patient further. The patient is in PICU, currently 4 hours of treatment already. The patient is sedated with fentanyl. Also, the patient was started on dexmedetomidine. Dexmedetomidine, the advantage here would be it would help to reduce the heart rate a little bit, probably help to get a better diastolic filling time. Lasix infusion was started. We continued epinephrine. The hemoglobin was on the lower side. So in order to increase the myocardial oxygen, in order to increase the oxygen carrying capacity, PRBC was transfused, and backs were almost up against the wall. So IVIG, although not associated with a lot of good quality evidence, but IVIG was started. Despite all these things, the patient continued to deteriorate. CVP went up to 14. The blood pressure was falling further. The liver was also becoming more enlarged, and a repeat echo at this point of time showed ejection fraction of 15%. By this time, we got back our troponin I and BNP levels, which were very high. Paraflu was positive on respiratory biofire panel. PBG was done, which showed mixed venous saturation of 15%. So the patient is, of course, at this point of time, the status is quite concerning. You can see the systolic blood pressure is low, the diastolic blood pressure is also low, and the mean blood pressure is also low for them. So what are the concerns and how will you manage? Okay, so I'm very concerned at this point of time with the blood pressure, not only with one component of blood pressure, but with all the components of blood pressure. Now, let us take one of the components of blood pressure one by one. So one is mean arterial blood pressure. So that is the average blood pressure. So this mainly determines our perfusion to different organs. So if our MAP is low, we definitely have to address that, because that will result in poor organ perfusion. As you can see, your SGPT, SGOT is slightly already on the higher side. The liver will become shocky. Your urine output is never going to come up unless you have a good perfusion pressure. Now coming to diastolic blood pressure, again, often I see as fellows, we fail to pay much importance, or we forget about this component of blood pressure sometimes. But diastolic blood pressure is very, very important under these circumstances. It is critical for coronary perfusion. So coronary perfusion is what? It is diastolic blood pressure minus left atrial pressure. And as a surrogate of left atrial pressure, we would say CVP. Okay, so diastolic blood pressure minus CVP. So we at least, for the coronaries to be well perfused, we at least need a diastolic blood pressure around 12 to 14. Okay, so under these circumstances, what was our diastolic blood pressure? It was 28 and CVP was 14. So our coronary perfusion pressure would be around 14. So this is just about borderline. Okay, so although at this point of time, we might not realize that our diastolic blood pressure has fallen, but this patient, we have to realize, is at a high chance of having a cardiac arrest because your coronaries are not getting perfused. So it's very important to have the diastolic blood pressure up and pay more importance to diastolic blood pressure. So at this point of time, what as an intensivist, what would be my goal would be to make the patient tighter a little bit in terms of mean arterial pressure, in terms of diastolic blood pressure. So I would like to add vasopressors at this point of time. We were already on some minor pros, but I would like to add vasopressors. So there is some good evidence now whether to add vasopressors in the management of cardiogenic shock. So in order to maintain your perfusion pressure and prevent organ failure, it is recommended that you add vasopressors. Okay. Having said that, you also have to be mindful that there is a chance of increasing the afterload of the already struggling ventricle. So it is a very fine balance. But at this point of time, because the blood pressure is like critically low, I will add vasopressor. Okay. Next 2 hours. Further deterioration, lactate increasing, mixed venous falling. You are already on adrenaline, noradrenaline, vasopressin. We wanted to be on milrinone. You reduce the afterload, but we are now off milrinone, okay? Because our blood pressure is critically low. Chest X-ray, you can see, is much worse. The ejection fraction similar. The patient has become anuric. So what are the options? So people still may try and optimize the patient, go further up on the inotropes, start for some forms of renal replacement therapies like CVV, HDF and whatnot. But at this point of time, I would rather not wait because this patient will crash and this patient will arrest immediately. So the question is ECMO or no ECMO? If we have the facilities, of course. If yes, what kind of ECMO and where to cannulate? Okay. For me, this patient is decompensating. Yes, ECMO for sure. What kind of ECMO? So I'm sure that you will get these answers. Everybody of you will get this answer correct. It has to be a VA ECMO because we need to support the heart. And where to cannulate? Will it be central or peripheral? I would cannulate peripherally. Venous access will be IJ. Arterial access will be carotid. Okay. So the patient was cannulated onto ECMO, put on ECMO, and the ECMO run was going on smooth. I'm not going to go into the settings and all. So again, another twist in the story. Okay. Now you see one day into ECMO run. This was our initial picture, and this is the picture 1 day later. So what has happened? The lungs have become white out. So can you see? Can you just think of what could be the cause of this? All right. So we have to realize, although ECMO will be beneficial in these circumstances in order to provide rest to the heart, but ECMO will also increase the afterload to the already struggling ventricle. Now, this is not an ECMO session, so I'm not going to go into all the details, but in these circumstances, while cannulating, we would always preemptively put something to vent the left side of the heart. Typically, our strategy in our unit would be to vent the LV through the right superior pulmonary vein. So that's exactly what we did. So this is not, this is just for the sake of the story. This patient was not initially having an LV vent. Once they picked up pulmonary edema on the picture next day, they put an LV vent. CRRT was initiated, chest X-ray. We improved over the next 4 days. The patient was waking up appropriately and was weaned off ECMO after 4 days. And now the patient gradually started to recover. The child was now on milrinone of 0.5, Lasix was made intermittent. The child was off inotropes. Urine output gradually picked up. The peripheries became warmer. The perfusion became better. Echo was getting better. Now, how do we plan for extubation and when to stop milrinone? Okay. So again, it will depend on your understanding and your unique policies. But typically, we at least have to see at least 24 hours of stability on positive pressure ventilation. After coming off ECMO, the patient is able to maintain reasonable perfusion pressure. So this child is like, about 3 years of age. So at least a map of 50 to 60, something between 50 to 60, on not a lot of inotropic support, not a lot of vasopressors, and with some milrinone still going, the child's urine output has picked up at least 1 ml per kilo per hour. And once everything is once you have satisfied all those criteria, which essentially means that the child is hemodynamically stable and has got good organ perfusion, you perform your spontaneous breathing trial, and if the spontaneous breathing trial is successful, I would extubate the child on some form of positive pressure ventilation to optimize the left side of the heart, which will be helpful for the left side of the heart. And once the child is extubated on NIV, then I will switch milrinone to an oral afterload reducing agent, which could be either enalapril or captopril. And next, my strategy will be to go from IV diuretics to oral diuretics. Okay. So take home messages, always under these circumstances, we have to be very act very fast, and always focus on hemodynamic stability, cautious inotropic and fluid use guided by clinical science and focus. Inotrope strategy: do not aim very high blood pressure because that will increase the afterload to the left side of the heart. Always focus on all the components of blood pressure: your systolic blood pressure, mean blood pressure, and diastolic blood pressure. Remember, ventilatory support is helpful for the heart. It reduces the afterload to the left side of the heart and optimizes oxygenation. And once your patient is stable, stabilize on inotropes and slowly transition to oral agents for long-term recovery. Okay. I'll quickly move to the second scenario because I'm running already late. I think I'll just try to finish this in about 10 minutes and so. Am I allowed to do that?
Yes, you can take it.
All right. So the second scenario is on an arrhythmia. So a 6-month-old child previously underwent a ductal stenting for a TET. The anatomy was a TET pulmonary atresia, now returned to our unit following a TET repair with transannular patch. Okay. The echo while coming off bypass showed that it was an adequate repair. There was no residual VSD. The surgeons had left a PFO which was shunting bidirectionally. Okay. And the RV systolic pressure was around 3/4 of the systemic. And after coming to the ITU, he was on reasonable inotropic supports, on not too high inotropic supports. So adrenaline of 0.1, NORAD of 0.05, milrinone of 0.25. Initial blood pressure for this age was quite okay. CBP was acceptable. Mixed venous saturation 55%, lactate 4.5, initial heart rate in 140s. So all very reasonable numbers. But what happened was over the next 45 minutes, heart rate went up to 160s, and it seemed to be a narrow complex rhythm on the monitor. So this is the monitor picture again. I'll pause for a couple of seconds here for you to answer in the answer box. So what do we think about this rhythm? Look at the heart rate, look at the rhythm, and you can mention what do you think? What kind of rhythm is this? Okay, moving forward, what are the different rhythm disorders which can happen in post-op TET patients, and do we think it's a sinus tachycardia? No, I don't think it's a sinus tachycardia. We'll see what it is. But some of the rhythm disturbances which are common in post-op TET patients, one is complete heart block. All the patients who undergo a ventriculotomy, right ventriculotomy, would have right bundle branch block, but that is usually clinically not significant. But the polling question which I had put up in the group yesterday: what is the most common form of malignant tachyarrhythmia in post-op cardiac children? This is JET. Okay, so JET, complete heart block, and right bundle branch block. These are the most common arrhythmias that we see in post-op TET patients. So what is JET? As the name suggests, it's junctional ectopic tachycardia. So it arises from the junction. What does that mean? It arises from in and around the AV node. So whatever surgeries we perform around that area, like around the AV node, are at high risk of going into junctional ectopic tachycardia. So these are TET repairs, typically VSD repairs, AVSD repairs. But having said that, many other surgeries also can go into JET, but these are the typical surgeries. So what are the characteristics? It's a narrow complex tachycardia. Okay, it's a narrow complex tachycardia. It is associated with AV dissociation. Now, why is that? I'll try to explain this. So the rhythm arises from the AV node, right? Whereas your normal sinus rhythm arises from the SA node. This rhythm arises from the AV node. Well, now what happens is, once the electrical impulse arises from the AV node, the impulse travels to the ventricle and to the atrium at the same time. Now, what might happen? There are few situations which can happen. One is depending on the timing of the electrical impulses moving to the atrium and the ventricle, your ventricle and atrium might contract at the same time, okay? Which means your P wave and QRS complexes will be merged, okay? The next scenario which can happen is your ventricle contracts first, followed by your atrium, okay? Which means the P wave will be coming after the QRS complex. So this is a retrograde P wave. The other thing which can happen is the P wave can happen before the QRS complex, which means the atrium is contracting like before the ventricle. So you have always the ventricle beating, but in some of the complexes, you have the P wave and the QRS complex merging together. In some of the complexes, you have the P wave following the QRS complex. So essentially, your QRS complex is always there, but your P wave may or may not be there. So this is AV dissociation, which means QRS complex is more than the number of P waves. So this is one of the most important hallmark characteristics of junction electrophic tachycardia. Your ventricular rate is faster than the atrial rate. It's an automatic tachycardia. So like any other automatic tachycardia, like sinus tachycardia, its onset is gradual. So we say it has got a warm-up period. It onsets gradually, like over 1 hour, over 2 hours, the heart rate goes up. And it has got a cool-down period. Even after you take appropriate interventions, the heart rate is slow to come down, okay? It has a cool-down period. And it's usually self-limiting, like within 72 hours to 8 days, it will usually come down. Okay, I already explained about this dissociation. So again, I'm looking at a rhythm strip. So what do we think? It's a narrow complex tachycardia. Okay, the QRS complexes are narrow. Now you see, here there is a P wave. It's coming before the P wave. Okay, so after the QRS complex. Here there is no P wave. So you have all the QRS complex, but which may or may not be associated with a P wave. So this is a typical AV dissociation. Okay, so with this knowledge, let's go back to our monitor picture. So this was a narrow complex tachycardia. There is loss of AV synchrony. Do we agree? So in the current context that the child has undergone a TET repair, this could be JET. Also, I would like to draw your attention to the CVP. Why is the CVP high? So essentially, in JET, you lose your AV synchrony. Okay, you lose your AV synchrony. What does that mean? So essentially, it means your atrium is contracting against a closed ventricle. So remember, what is the fourth phase of the cardiac cycle? It's the rapid atrial filling phase. So essentially, your AV valve is open, your atrium contracts, and you have blood moving into your ventricle and the heart ejecting out. So this is the last phase of the cardiac cycle. This amounts to around 25% of cardiac output. Now, in JET, because you lose this AV synchrony, the atrium contracts against a closed AV valve. So what happens? Two things happen. One is because the atrium contracts against a closed AV valve, you have a higher CVP and you have spikes on your CVP wave. Second is you lose this 25% cardiac output. Now for me, for any adult or for a bigger child, this 25% loss of cardiac output may not matter. But for an infant, it totally matters. The child can go into a low cardiac output state. So that is why we always go mad about that. We have to control this rhythm. Okay. Now coming to diagnosis, although it's a narrow complex tachycardia, the diagnosis is not always easy. And whatever said and done, although we said that AV dissociation, these things and that things, the AV dissociation is not always easy to pick up. Okay. So there are some diagnostic methods. What in cardiac ICU we do something called AVR study. I'm not sure how many of you work in post-op ICUs, but AVR studies are done with our pacing wires. So all our cardiac patients nowadays will come back with pacing wires for us to be able to pace the heart if required, if the heart rate falls down. Okay, so there are two sets of pacing wires, usually one set in the right atrium, so two right atrial wires and one in the right ventricle, so two right ventricular wires. So if you have these pacing wires, you would be able to record an ECG directly by using these atrial wires, which actually allows you to record the electrical waves directly from the epicardiums. Normal ECG, what happens? You are doing a surface ECG. So essentially, electrical impulses are generating from the heart, then it gets impeded by your soft tissue, muscles, and stuff. In AVR study, you are amplifying your electrical impulses. So in that way, P waves, which were not visible quite, may become more visible. Now, how to do AVR study? I'm just skipping the slides for the want of time, and also I think it might not be of interest to you unless you are working in a post-op cardiac unit. If you are interested, I'm happy to you can directly text me or ask me later on. Okay. But AOR study is something by which we can our diagnosis of JET becomes a bit more easier. Okay, now coming back to our patient, in the next 30 minutes, initially the patient had come back with a heart rate of 140, now has gone up to 160s, and now it became more higher, became even more higher. So as I said, that it has got a warm-up period, and the patient gradually, we can see all the telltale signs of low cardiac output now setting in. The patient has got fuller extremities, the patient has got poor pedal pulses, the rectal temperature is coming high, the CVP has become high, the blood pressure has started to fall, lactate has started to creep up, mixed venous saturation is falling further. So I already mentioned this, do not take JET lightly. If you have already diagnosed, always we have to treat aggressively. And why is that? One is JET is a tachycardia. So you lose your diastolic time. So the cardiac output is going to fall anyway. And because of this AV asynchrony, you lose 25% of ventricular filling. So that is going to be even more detrimental. So we have to be very, very aggressive at treating JET. Now, what are the goals of intervention? Now, JET is a rhythm which is very, very difficult to control. So our primary goal is to control the rate, not the rhythm. Okay. And secondary goal is to achieve AV symphony. So what do? All the things that we do to bring an automaticity down. So what are the stimulations for automaticity? It's your temperature, it's your electrolytes, it's your inotrope. So all those things. If the child is very agitated, the heart rate will go up. If the child is on high inotropic support, the heart rate will go up. If the child is febrile, the heart rate will go up. So what do? We try to optimize the inotropes. Your potassium, magnesium, these are very important. Okay. If the child is febrile, cool the child down. Often we'll cool the child down to 35 degrees. Okay. And once the child is cooled, always while the child is cooled, if you're applying ice, make sure that you paralyze the child so that the child does not start to shiver, because that will cause shivering thermogenesis. Okay. And it's again easier said than done, but if possible, try to reduce the inotropes and catecholamines. Again, in the post-op child, it may not be possible, but if you are able to reduce a little bit, that will reduce the automaticity. So these are the general measures, but very, very important measures. Okay. You optimize your analgesia. If the child is very agitated, optimize the analgesia and sedation. The post-op child is very important. You use morphine. You can use dexmedetomidine. Again, dexmedetomidine will have an added advantage in this situation because it reduces the heart rate. And you correct your hypoxia, you correct your acidosis, you correct anemia if that is present. If there is a scope to give some volume, you have to give some volume. Okay. Specific measures. So even after all these measures, if the child remains unstable, then we have to think about drugs. Now, what are the drugs which are available? Now, there is some good evidences, good papers from India also coming out about, I have not mentioned here, but about an enteral drug called ivabradine. So ivabradine can be very useful. We use in our unit also. So in these circumstances, we would always do these general measures as I already spoke about, and then through an NG tube, we will just give the first dose of ivabradine. And along with that, if the patient still continues to we'll optimize the electrolytes. Magnesium is a very important electrolyte, let me tell you. And if the patient still continues to be in these rhythm, then we will give IV amiodarone. And I'll just say a brief few things about IV amiodarone. So IV amiodarone, your typical textbook teaching would be to give a loading dose of 5 milligram per kilo. Now, I never do that. And I've spoken to so many, I've come across so many cardiac intensivists. Most of the cardiac intensivists would not do that. And this is something I picked up from my practices abroad. So always, whatever said and done, I do not give amiodarone in this bolus dose of 5 milligram per kilo. I would use in very small aliquots, usually 1 milligram per kilo, and that too over 30 minutes to 45 minutes, and see the response. Many a times it so happens that I will give 1 milligram per kilo, the patient did not respond. I'll give another 1 milligram per kilo, another 1 milligram per kilo. The patient might respond to 3 milligram per kilo. The heart rate might start to come down. I might not require to give the entire 5 milligram per kilo, because remember that amiodarone has got a super negative inotropic potential. So it can totally cause further deterioration in an already hemodynamically compromised child. And it's a long-acting drug. So once you have given the entire dose of amiodarone, if the patient's ventricular function dips, you are in a problem. Okay. So IV amiodarone, we have to be very, very careful. Sometimes people skip the loading dose totally. They would just start on an infusion. And once you achieve a reduction of heart rate, remember I said that reduction of heart rate is a primary goal. Then we will use the pacing wires in order to pace the child, in order to achieve AV symphony. Again, something which I'm not going into detail of very much. And in refractory cases, these patients, even if they do not respond to all these measures, we have to support them by means of ECMO. Remember that this is a self-limiting rhythm. So if we can support them hemodynamically by means of ECMO, you can have very good results. So what did we do in these circumstances? We cooled the patient down to 36 degrees Celsius. We reduced our inotropes. The electrolytes were optimized. Magnesium was corrected. The patient was sedated with dexmedetomidine. Over the next 2 hours, the patient's heart rate started to come down, and then we paced at 155. Okay. But again, remember that this is a very, like nagging rhythm. Next day, what we saw was, again, the heart rate went up. At the point of time, it is very, very important, the post-op child, to look into the residuals, to do a repeat echo. Remember these points, okay? Because sometimes we might have missed some residuals in the OR, okay? And these residuals might be actually the cause of this lingering jet, okay? So echo was done to rule out any residuals. The child was started on IV amiodarone. The child remained stable over the next 48 hours. The muscle relaxation was gradually lifted now that we knew that the patient was out of jet for a reliable period of time. The sedation was slowly weaned off. The child was rewarmed to normothermia and was extubated on POD3. All right. So always remember, jet, the learning points would be that whenever a child is coming back from the OR, we have to be very, very mindful about what kind of rhythm the child is in. If the child is becoming tachycardic, look at the monitor. If required, involve your cardiology friends quickly to see if there is a sinus tachycardia or you are dealing with some other tachycardia, even if it's a narrow complex tachycardia. If the patient is diagnosed with jet, do all the things to control the rate. And once you have controlled the rate, then you can pace the child in order to achieve episynchrony. Okay. With that, I'll come to the end of the presentation. And if you have any questions, I'll be more than happy to answer. So for the want of time, I know this was supposed to be a session on arrhythmia, but I thought that, let us just discuss about one arrhythmia. Then the teaching will be better because we already discussed significantly on myocarditis. So I don't think that if I just talked about all the arrhythmias in a short span of time, it would have done justice. So thank you very much for your patient hearing.
Thank you, Dr. Shubhadeep, for your wonderful presentation. There are a few questions, Dr. Manendra. Please coordinate with Dr. Sajit and Dr. Dharmender.
Yes, sir. Thank you, Shubhadeep. We have a few questions. I think so. I'll ask them one by one. So what? So first, I'll ask Sajit, because Shubhadeep might have to go for the booking, right?
Yeah, I still have.
Sajit, are you there?
But then I have to peel off. It will be very helpful if Sajit takes over.
You can leave whenever you wish. Don't worry.
Okay, so I'm here. I'm here now.
Okay, the question is basically, Shubhadeep, over to you. What about salbutamol nebulization in cardiogenic shock? Sometimes you want to use it or push to use it. What do you do when there's already so much tachycardia?
Yeah. So as I said, again, there is no hard and fast rule. It's initially, in the initial phase, it's very difficult to differentiate between a child with bronchiolitis or, a wheezy illness versus a cardiogenic shock. So I think most of us, if this patient came to us in the emergency, most of us would nebulize with salbutamol. But we have to see the response. It's my practice is I would nebulize with salbutamol probably for a couple of times, 3 times, and see if the V's are responding to salbutamol or if the patient is becoming more tachycardic without any response. Okay, so if I would not interpret by a single clinical sign, I would put everything into clinical context. I would see what is the response with salbutamol, what are the signs of perfusion like, if the child is not only tachycardic, if the child has got a prolonged cap refill time, if the pulses are poorly palpable. If I think that on my list of diagnosis, cardiogenic shock is much higher rather than a wheezy illness, then I would, at this point of time, I would probably support them with some form of non-invasive ventilatory support. If the child has got wheezes, I would probably still continue to use salbutamol, but not very frequently, because the cause of wheeze here is not reactive airway disease per se, but overall your pulmonary congestion.
Okay. So this is to you, Sajid. I know Shubhadeep answered about the IVIG. So is it a routine in your unit to give IVIG and steroids or steroids for mild myocarditis?
So we don't use either of them unless we are dealing with MISC. I mean, at the time during the time that we had MISC, it was a routine practice to use both steroids and IVIG for all myocarditis because MISC does respond to that. We are not very sure whether all viral myocarditis are the same. If you look at internationally, majority of the units would still use it, but our cardiologists who are quite good in this, they feel that the money that is used for IVIG might better be used for better supportive management. In terms of steroids, the indication would be if there is a lot of arrhythmias, if the ejection fraction is really low, because what steroids does is it does not really improve the mortality, but it does increase the ejection fraction and it does decrease your arrhythmic burden. So in those two scenarios, we would use steroids, or we are suspecting some kind of rheumatological diagnosis or something other than viral myocarditis. In a lot of these patients, it is not really clear whether we are dealing with viral myocarditis, but if you're sure it is a viral myocarditis, even though we don't do MRI and endomyocardial biopsy in all of these patients, if we get a viral PCR positive and there is a viral prodrome and it looks sufficiently acute enough, and then we think that it is acute viral myocarditis, our practice is to use IVIG quite sparingly and steroids only if there is these indications that I mentioned.
Okay. So one more question to Shubhadeep. Now you are discussed only viral myocarditis. Suppose the patient has a superadded sepsis also. Would your inotrope and vasopressors change as per the scenario?
Yeah, as per the scenario, definitely. Because under those circumstances, depending on what kind of state, the hemodynamic state the patient in, the patient might be in cold shock. So the patient might require more inotropes. Okay. So sometimes if you are having very low blood pressure, you might still need to add vasopressors. So I mean, depending on the scenario, yes, your inotropic support would still change. I mean, sometimes in sepsis with superadded sepsis, whatever said and done, you might actually struggle to generate enough perfusion pressure. But then my point would be, if you have the facilities of supporting with extracorporeal therapy, even though the patient is septic, do that rather rather than late.
Okay. Now I'll go to Sajid again. So what is your practice of first inotropes in myocarditis? Is it low dose epinephrine or dobutamine with norepi?
So if the patient is hypotensive, then it is low dose epinephrine. If the patient is not hypotensive, then it is milrinone. We might use dobutamine as well in the very acute initial phase, but because we are a referral center, we get patients after the diagnosis is made. So then that we would be using more of milrinone. The advantage of dobutamine over milrinone is simply the fact that it is titratable, because milrinone, or use milrinone without loading. If you give a loading dose of milrinone and we use a milrinone infusion, if you run into trouble, even if you stop milrinone, the effect might last for some time. So for its titratable effect, dobutamine might be preferred. For example, somebody is in an ER in a periphery where they don't have, those kind of luxury of using extracorporeal support and all of that. If they were to choose something in the very acute initial phase with somebody with a normal blood pressure, dobutamine, and somebody with a low blood pressure, low dose epi.
Okay. So there again,
I'll just peel off for some time.
Hello, is anybody talking?
I think Dr. Maninder is traveling and there is some network issue. So
Maybe we can look at other questions in the chat. There is a question about role of steroids in non-MISC myocarditis. So I've shared our unit practice of using it in very severe low ejection fraction as well as when you have a high arrhythmia. What about you, Dr. Dhirendra? What do you think about steroids in non-MISC myocarditis?
So there is no clear evidence to support that we use the steroid in non-MISC myocarditis, but we use sometimes when the inflammatory or the cytokine storm and it supported it. So we start the steroid in that case only, but there is no clear-cut evidence for support it.
Next question is, will there be change in anatropes if you have both steps? That is already covered. And then the next question is, that is raised by you as well. Which pediatric arrhythmias should be cardioverted early rather than attempted medically? So when it comes to arrhythmias, any arrhythmias which have significant hemodynamic instability, you should be thinking about using cardioversion. Or if you have a lethal arrhythmia, then again, you must be thinking of cardioversion. But even if it's a lethal arrhythmia, if the patient is hemodynamically stable, then we should be trying to treat it medically rather than with cardioversion, because some of these patients might not even be intubated, and for doing electric cardioversion, sometimes you have to be prepared for securing airway and all of that, because at the time of doing the cardioversion, sometimes you can push the patient into a cardiac arrest as well. So you might want to treat medically before you go into electrical cardioversion. But if you are dealing with a very hemodynamically unstable patient, their cardioversion has to be thought of even before medical management, because some of these medicines which are used for a medical cardioversion might cause further depression of cardiac function and worsen the hemodynamic status.
Thank you,
Any
sir.
questions from the audience? Any questions?
So they have asked, basically, I'll ask Dhirinder first. Levosimendan versus Milrinone. Which one do you use and why? Then I'll go to Sajid also for same question.
Sir, we use levosimendan in RPICU when there is permanent myocarditis or there is a low cardiac output state, and child is already on milrinone and low dose of non-epinephrine and showing sign of poor perfusion or rising lactate. So we use levosimendan in that case. But before starting levosimendan, we give a trial of milrinone plus norepinephrine. Sir, we don't use the loading dose, and the unique advantage of levosimendan is that its more metabolite is active for 7 to 10 days. So biggest benefit.
So what
So
about you, Sajid? Do you follow the same practice?
We never use levosimendan in the acute phase. So in the ER, in the first few days, we would be using more of our titratable inotropes and dilators. We would be using, for example, if we have put somebody on ECMO and we are coming off ECMO, the previous day of ECMO, we would be giving a levosimendan infusion, or a patient who is just going to be weaned in the pathway to recovery, where they still have very low ejection fraction, and we want something long term. But then we have other drugs for that. We have NVAS and oral other dilators. So we mainly use levosimendan in the setting where we are weaning off ECMO. Otherwise, we have not used levosimendan.
Okay. And then there is one question about amiodarone. When do you want to use it? Over to Sajid.
So amiodarone is used when you have an arrhythmia, which is in the postoperative setting. We use an arrhythmia which do not respond to our normal treatment, like we have somebody with jet or something. We would try non-medical interventions like cooling and correcting magnesium and all of that. And then still, if we have an issue, we would use amiodarone. The second scenario is when we have a ventricular arrhythmia, where we have to medically cardiovert them. We would use amiodarone infusion. And like Shubhdi mentioned, it is better to use it as an infusion rather than as a loading dose, unless you use it for the VFVT refractory algorithm in an acute CPR settings, where sometimes it is used as a loading as well. But anytime we are using amiodarone, we have to understand that amiodarone is a drug with potential complications, mainly in terms of hemodynamic instability, as well as it's not a very great drug to use it long term because of its multiple side effects. But it is a very good antiarrhythmic in the sense that it is like carpet bombing. It covers all arrhythmias. It's not unique to just ventricular. It covers SVT, it covers VT, it covers atrial ectopics. So the most broad spectrum antiarrhythmic ever is amiodarone. But remember about its side effects.
I'm open to
Okay.
take questions now.
Shubhadeep, for you only. They are saying in any myocarditis, they give low dose steroids.
Mhm.
So this is a general practice. Is it right?
So no, we do not practice this, and I would not advocate this. So as Sajid was mentioning, there are some settings, not again very much evidence based, but there are some settings where we would still use steroids. Typically, one would be that MISC scenario. One would be sometimes, like Kawasaki disease can present with myocarditis. We have treated a few. The role of steroids would typically be there, but then all myocarditis would not. I would not give steroids. But then, if we are not an ECMO center, if we do not have ECMO, and the child is very much hemodynamically unstable with a lot of inotropes, our back is completely stuck against the wall, then what to do? We have to try all the options to salvage the patient. At that point of time, IVIG, steroids, whatever we have in our hand, yes, definitely. But if we are in a center where we have the ability to support the patient and we are on the reasonable amount of inotropic supports, the patient is borderline, but then the patient is still stable, I would not give steroids routinely. And some of the other
Okay.
indications, like recently I managed a patient only 3-4 days ago. Like this was a patient who underwent a heart transplant in MGM Chennai and presented to us with acute heart failure cardiogenic shock because of an acute rejection. So in those circumstances, yes, steroid definitely. This is another indication because we have to immunosuppress. So that's a completely different scenario presented with cardiogenic shock. We have to suppress the immunity as soon as possible. Steroids, yes, but then not all the indications. Typically, if we have a already viral etiology and stuff, I would not routinely use steroids.
Perfect. Perfect. So once you are stuck against the wall, then otherwise it's not the first line as usually which is practiced in other units. Okay. So there's one last question before we close. They are saying in a cold shock and wet, when do you start a diuretic?
So as I said, like diuretics, most of the people would start because you can see, like on your, as I showed you, on your lung ultrasound, you could see the B lines on your lung USG. You could see the IVC was distended. You would see that you would start diuretics once you have like good numbers of blood pressure. Once you probably for this child, if the MAP is more than 45 for a 3-year-old, I would start diuretics. But also we have to be mindful of the fact for diuretics to act, you need to have good GFR. You need to have good perfusion to the kidneys. So diuretics we add, but may not work very well under these circumstances. So many of the units would support this patient with some form of CRRT, with some form of renal replacement therapy, RRT. So depending on the availability. But diuretics may
So
or not.
Sajid, which one, PD or CRRT?
So it depends on the size of the child. If the size of the child is small, PD works beautifully. Infants, I would definitely choose PD over CRRT. If somebody is older, like our cutoff would be somebody who's more than 10 kilos, we would be choosing CRRT over PD. But that
I
also
agree with
depends
this.
on other factors, like whether they're already intubated, whether they are, bleeding, they have coagulopathy, they have something wrong with their abdomen, whether they have dengue. I mean, a lot of factors are there, but in general, size would be one of the main criteria.
Because in bigger children, what we see is in bigger children, acute PD does not work very well. Yes, you can still get home PD and chronic PD, but acute PD in bigger children does not work. So yeah, I agree with Sajid's viewpoint, more than 10 kilos or probably 15 kilos. We would definitely think about CRRT.
So one last practical question. In a cardiogenic cold shock, is BP really reliable to Dharinder? And how do you actually measure BP in such children, intubated versus non-intubated?
Sir, NIBP is not reliable in these circumstances. In non-intubated children, child is very irritable, agitated, and the NIBP is not totally reliable. So we totally rely on the IBP only. So we target only the IBP. After intubating, we put a arterial line and the target the IBP and MAP.
So Subhajit, do you agree with that?
Sorry?
So Do you agree with that? That arterial BP is very important in managing such shocks.
Yes, yes, absolutely, absolutely. Arterial BP is the gold standard. Absolutely.
Done. I think so. We have finished our question and answer session, and it was amazing. It was a difficult topic. I thank Shubhadeep and Sajid and Harinder to have taken all the questions and made it more practical. I know it was a bouncer class because cardiogenic is always bouncer. It starts with the rhythm and hits the heart directly. So it's difficult. I know that. So over to Dr. Dinesh Goyal and Dr. Ajay to please close the session.
Okay, it was a
Yeah,
wonderful
Dr. Ajay, sir,
session,
please, yes.
and Dr. Shubhadeep has made it really interesting, and Dr. Sajid and Dr. Dhirendra were also great. Over to Dr. Dinesh.
Thank you, Dr. Ajay, sir. Thank you, Dr. Maninder. ऐसा लगता है कि जैसे एरिथमियास पढ़ के एरिथमिया ना हो जाए यार, इतना ज्यादा सोचना पड़ता है. एंड हाउ यू
मिस
पीपल डील
हार्टबीट
विद
है,
दिस
हार्टबीट मिस हो गई है.
yes, exactly. And dealing with this such a difficult scenarios with so much clearness, and it's really very heartening to listen you people. And thank you so much on the behalf of IIP Delhi, and thank you so much for such a wonderful learning sessions for the. And I hope we are successful in imparting the knowledge, or you can say transferring the knowledge to the youngsters. And definitely, whenever we have a case in emergency and we are confused with whether it's a respiratory cause, cardiac cause, then we attach the cardiac monitors and we found it's a cardiac cause. Everybody is, frightened, and they start calling pediatric cardiologists or whatever cardiologist is available in the hospital. But there's a big difference between adult cardiology and pediatric cardiology, and dealing with the kids is definitely a difficult difficult scenarios. So thank you for so much clearness, and thank you for enlightening us such a wonderful knowledge. Once again, thank you, Dr. Maninder.
Thank you, sir. Thank you. Thank you,
Thank
Sajid.
you.
Thank you, Shubhadeep.
Thank you. And
Thank
thank
you.
you, Shubhadeep. Thank
Happy
you,
Sunday.
Thank you.
Sajid, and everyone. Thank you so much. Thank you.
Thank you very
Thank
much.
you all. I hope Shubhadeep got his ticket.
Yes. Okay.